Hello guys, how are you? I hope that you are doing well. My name is Dr. Mario Guzman. I'm a professor of counseling and psychology at Trinity Christian College. And I'm doing this recording for my class of psychopathology. I'm going to talk about anxiety and stress-related disorders. And I thought to share this with all of you so you can learn more about these two topics that are so important and prevalent in our society nowadays. So I hope that you can have some insights about this and that you can also see this as an opportunity to learn more and to try to continue your process of understanding better mental health issues and mental disorders, of course, and psychological treatments for mental disorders. All right, so the way that I'm gonna have this conversation with you is I have a PowerPoint presentation. I'm going to share that in my screen and I'm going to walk you through that PowerPoint presentation and we're going to talk about the topics there. Most of the information that you're going to see there was taken by this book, from this book that it's called Psychopathology, Research, Assessment, and Treatment in Clinical Psychology. It's a very interesting book. I really like. It's a book that can help for those who are beginners or that are starting to study mental health problems, psychopathology. It's a very clear book with a lot of examples, very assertive information there. But it is also a good book for those of you who perhaps have more experience, that you have been working in the field of mental health for a while. I will still suggest to read the book because it has a very I would say very important information, but at the same time, it's an information that it's actualized, and yeah, so it's a good book. It's a good book. Okay, so that's one of the sources. The other source that we're going to be using is the DSM-5, of course. As for those of you that are starting in the field of mental health, the DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders. It's published by the American Psychiatric Association, and it's a book that counselors, psychologists, psychiatrists, we use to try to come with a diagnosis for our clients. And I think that they did a good job in this edition. I know it has been under a lot of criticism, and some of those criticisms, I think that it's a fair criticism, but at the same time, I think that it's a good book that can help us to have a common language, that can help us to understand what are we talking about, that we can communicate with other professionals such as psychologists, psychiatrists, social workers, counselors, and so on. And also, it's a good book that can help us providing not only diagnostic information, or not only some guidance to try to see what is the diagnosis that our client has, but also in this edition, they share some of the, I would say, some of the information that research is bringing about these disorders. As you know, the DSM has always tried to be I don't know if it's the right way to say it or not, but at least they have tried to be neutral regarding theoretical positions. And they are still trying to do that in this edition. So you are not going to see information that it's more inclined to CBT or more inclined to psychoanalysis or more inclined to psychopharmacology or things like that. But they are trying to provide some ideas or to share some ideas that research has proved that are present in the disorders that the DSM is talking about. Now, some of the criticism, as I was saying, is that seems that the DSM, it's trying to diagnose everything, all type of human suffering, right? And that it's not leaving room for understanding human suffering as a natural process. Yeah, maybe, I'm not so sure that they are doing that. other criticism that has received is that the DSM seems that it's a good fit for the big pharmas, and that the big pharmas are using this for marketing their products, their medicines. It might be the case. We know that there's a over medication in many people with many different type of disorders. And as we know, research is showing that the first way of treating mental disorders should be psychotherapy, counseling. And if psychotherapy is not effective, then you can use medicine along with the psychotherapy to try to improve the results with the clients. We can use medicine as the first way to treat our clients when the case is really severe, when there's a risk for the integrity of the client, patient, or for someone else, or when psychotherapy has been used and was not really effective. Then you can start with medicines at that time. But pretty much all the information that we have is telling us that for mild and moderate disorders, you can go with psychotherapy. And for severe disorders, you can use a combination of psychotherapy and medicines, right? Also, it's important to have in mind that there are a couple of disorders such as psychotic disorders and bipolar disorders that you want to start using medicine pretty much since the beginning, because if they go to psychotic breaks or if they have the mania stage, it's going to be very difficult for them, for you also as a counselor or practitioner. And we know that there's also brain damage every time that they are having these psychotic breakdowns or things like that. So you want to be careful with that too. All right, so having said that, that was just an introduction for you to know that I'm going to be using information from these two books, and maybe you want to take a look on them. If you are a counselor, or if you are planning to be a counselor, a psychologist, or whatever, you really need to have this one. And this book is going to be very useful because it's in a very integrated way, providing information not only about the disorders, but also about the etiology of the disorder, and also about the treatment for the disorder, which you are not going to find that in the DSM-5, okay? All right, so let me share with you my screen so you can see my presentation. And I'm going to open this. Sorry for that. I was just trying to make that clearer for me. All right, so these are the topics that we're going to be talking, or the big topic that we're going to be talking today: anxiety and stressor-related problems. As I mentioned, this is part of the psychopathology class in the master program that we have at Trinity Christian College. If you want to know more about what we are doing there, I'm going to share with you the link so you can take a look on that, okay? And I have a quote from Marcus Aurelius to start this presentation. For those of you that perhaps don't know who's Marcus Aurelius or who was Marcus Aurelius, he was a great, great, great Roman emperor. Some people said that he was the best emperor in Rome. I think so. I mean, I'm not an expert in Roman history, but he has a beautiful book that is called Meditations. And I strongly suggest you to buy that book, read that book. He was part of the school of philosophy that is known as Stoicism, which is the philosophy that is behind CBT, cognitive behavioral therapy. And it's actually, I can tell you, it's not a philosophy in the sense of a theoretical philosophy, but it's a practical philosophy. It's a philosophy to know how to cope and how to face life and adversity. So it's a great, great way of philosophy. And Marcus Aurelius' book, it's really beautiful book that has been inspiration for many of the great figures of human history. So you might want to go and read that book, okay? So objective judgment now, at this very moment. Unselfish action now, at this very moment. Willing acceptance now, at this very moment, of all external events. That's all you need. So why is that I choose this quote from Marcus Aurelius? Because he's telling us 3 things that we are not going to see in our clients with anxiety and stress-related problems. And that is objective judgment. It's not present. Most of our clients with anxiety and stress problems, they're going to have their cognitive biases are going to be activated. And because of that, they're going to have an non-accurate perspective of reality. Their irrational beliefs are going to be present, and they're going to have a tendency either to anticipate, to catastrophize, all or nothing thinking, tunnel vision, mind reading, jumping to conclusions. And these cognitive biases are going to be behind the type of automatic thoughts that they have that are connected with the levels of anxiety and the coping strategies that they are using that, of course, are not a healthy coping strategies. On the contrary, they are reinforcing their disorder. Most part of the time, they are using avoidance as the coping strategy, which is not a good way to cope with anxiety or with stress. So there's no objective judgment. They have a lot of cognitive biases that are activated. On selfish action, I would like to say that they are not unselfish, that they are not selfish in the sense, or clients with anxiety and stress problems, they are not selfish in the sense that they don't care about others, but they are, we could say, selfish in the sense that they are overly thinking about themselves, about their reactions, about how are they doing, about what is going on with them, and they stop thinking about what's going on around other people, around the others. Now, they do think about others, but they think about others in relation to them. What are they going to say about me? What are they thinking? They're going to think that I'm not capable. They're going to think that I'm a terrible person, and so on. So that's why I think that this quote is also related to what happened with them and willing acceptance. So one of the techniques that we use in CBT is radical acceptance, right? And it's the radical acceptance of reality as it is, and to understand that there are things that are under our control and things that are not under our control. And I think that's one of the lessons of another great philosopher from Stoicism, that his name was Epictetus, which I also strongly suggest you to read him. He has a beautiful book that it's called Enchiridion, which means manual. And he starts his book precisely with that, explaining that there are things under your control and things that are not under your control. And then he says, what's the point of being thinking and paying attention so much to those things that are out of your control? If you pay attention to what is under your control, then you're going to be able to experiment eudaimonia, which is the authentic happiness, as Martin Seligman called it, right? All right, that's just the beginning. These are the 9 topics that we're going to see today. There's no such thing as a dragon. It's a beautiful story that I want to share with you. It's a kid's book. Then we're going to talk about panic attacks and the fight, flight, freeze response, the specific phobias, common errors in our thinking, social anxiety disorder, agoraphobia, generalized anxiety disorder, obsessive compulsive disorder, and post-traumatic stress disorder. We'll see how this goes. It's going to be, it's not going to be a short video, that's for sure, guys. So this is a very nice book. I strongly suggest you to read it. It's a kid's book. My kids love this book. I have read this book several times to them. And it's a story of a kid that he wakes up in the morning and he realized that in his room, there's a little dragon that is the size of a kitty cat, right? It's a small size. And he's surprised to see a dragon there. And he goes with his mom and says, like, hey, mom, there's a dragon in my room. And the mom is like, no, buddy, there's no such thing as a dragon. Don't say nonsense. So the kid is really confused, but he trusts in his mom and he goes to his room. And when he goes to his room, he sees that in reality, the dragon is still there. But he's saying to himself, there's no such thing as a dragon, there's no such thing as a dragon. So he tries to avoid the dragon, to ignore the dragon. So he takes a shower, and when he comes out, the dragon is bigger now. And he's surprised to see that now it's not the size of a little cat, but now it's the size of a big dog. And he's like, what happened? But then he remembers what the mom says, there's no such thing as a dragon. And he tries to ignore the dragon. Then he goes downstairs, and the dragon is bigger now. He's bigger like a bull, like a, I don't know, like an elephant. He's really big, and he's messing with his breakfast, and he's making a mess there. And the mom is pretending that she doesn't see the dragon. So the kid is like, well, there's no such thing as a dragon. He goes with the flow, right? Then the dragon is so big that he's occupying the whole house. And even though the mom is still denying the existence of the dragon, and the kid is going with the flow. There's this time that the dragon is so big that his head is going outside from the main door, from the front door, and the tail from the backyard door, right? And the dragon is there, he's taking a nap, as you can see in the image, but suddenly something very interesting happened. An ice cream truck goes by the street, and the dragon, he loves ice creams, and he wakes up and he starts chasing the ice cream truck. But there's a problem. It's so big now, and he has occupied the whole house, that the whole house goes in his back as a shell, right? He's running behind the ice cream truck, and he's having this house behind him, and the mom and the kid are inside of it, right? So the father comes from work, and he finds no wife, no kid, and no house at all. So he's really surprised. He doesn't understand what happens. So the mailman says to him, I know where's your family and where's your house. A dragon is chasing an ice cream truck, and he has your house in the back. So the father cannot believe what he's listening, but he goes to look for his family, and he finds the dragon with the house and the family there, and the dragon is having ice creams, is having a nice time. And the father says, like, what happened? And the kid says, like, the dragon. And the mom, sweetie, there's no such thing as a dragon. Stop saying nonsense. And the father says, like, honey, I think that there's a dragon. And we need to admit that. We need to accept that. And the boy says, like, yes, mom, there's a dragon. And the boy starts petting the dragon. And something very interesting happens. The dragon starts coming smaller, 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 until he goes back to that little cat size from the beginning. And the mom says, like, well, a dragon of this size, it doesn't bother me as much, I guess so. And then the family and the story ends there. And yeah, so there's a beautiful moral behind this book. And that moral is, we will have to face dragons in many times, in many different moments of our lives. I think that's what it's behind also the St. George story of the dragons. If you are not familiarized with St. George story, he's the patron of Europe, and he's pretty much represented by in his horse killing a dragon, right? And that's also behind many other stories about dragons. They are telling us we're gonna have to face these monsters, these things that they are threatening us and that they are causing us fear, anxiety, stress. And we have two options. Either we avoid them or we face them. And avoidance, as I mentioned since the beginning, is a very common practice for people with anxiety disorders, because when you avoid something that you are afraid of, you feel a relief in that moment. But then what happens is that you are reinforcing your anxiety for that thing. That's why people who have phobia to dogs or phobia to airplanes or whatever, the more they are avoiding those stimuli, those objects, the more their phobia is going to increase, right? So G.K. Chesterton, who was a great writer from England, he says something like, those who are brave enough to face their dragons in their lives they might realize that in reality, they were not dragons, but just lizards. And I think that's something that our clients see very often when we start working with them in therapy, and we help them to confront, to face, to cope with the anxiety that they are experimenting instead of avoiding that anxiety. So, all right, so that's just an introductory story for you to have in mind. What we want to do with our clients is to help them to face their anxiety, not to avoid their anxiety. And that's why it's important to be careful with medicines as well, because medicines can work as an avoidance strategy for them and perpetuate or reinforce their anxiety problem instead of overcoming their anxiety problem, okay? So panic attacks, the reason of why I choose panic attacks as the first topic is because panic attacks, they are not a disorder per se, but they can be present in many different disorders, not only in anxiety disorders, but also in stress-related problems such as PTSD or obsessive compulsive disorder, and even in depression. That's why so many people get the double diagnosis of depression along with anxiety, because panic attacks can be very common in many disorders. And not only in disorders, to be honest with you, panic attacks can be also a pretty normal experience for people that are experimenting threatening situations, or that they are under a lot of stress. So for example, if you receive a very bad diagnosis, or if you learn that a loved one has been killed or dead, or if you are in the middle of an earthquake or something like that, well, a panic attack can be even a natural, expected response under those situations, okay? So that's why we don't think that panic attack is a disorder, but it's, I would say, a manifestation of symptoms that can be present in many disorders. And you want to really have this very clear to understand the symptoms of panic attacks, so you can identify when they are present in your clients. So a panic attack, according to the DSM-5, is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the following symptoms occur. Note, the abrupt surge can occur from a calm state or an anxious state. So the person can be either relaxed, having fun, not being concerned about anything, and suddenly have the symptoms, at least 4 of the following 13 symptoms that we're going to see, or the person can be in a stage of anxiety, and then the anxiety increase to present the symptoms of the panic attack, okay? Now, something important to say is that it says reaches a peak within minutes. Normally, generally speaking, it's in between 10 minutes that the person is going to experiment the peak of these symptoms, okay? And that is also a good news for one reason. After minute 10, generally speaking, people start experimenting a relief of their anxiety, okay? I want to do something for you to show you. This is the anxiety curve that we use with many of our clients to explain what's going to happen. So 0, 0, 100. Okay. So what happens is that people can be, for example, in 0 and suddenly have the panic attack and going to 100 in matters of 10 minutes. And then the person has to make a decision. And that decision is, what are they going to do with their panic attack? If they are able to stay with a panic attack, to work with cognitive, behavioral, and emotional strategies for their panic attack, what is going to happen is that they're going to overcome the panic attack. And that's going to be an important thing, because now the brain has learned that they can cope with the panic attack, that they are not going to die for a panic attack. And what is going to happen is that they are working towards reducing the frequency and the intensity of those panic attacks. But what happens if the person decides that he or she is going to avoid the feeling that he or she is having, and before reaching 100, or once that they are in 100, they want to go back to zero where they were at the beginning, perhaps using a medicine, perhaps using alcohol, drugs, or perhaps avoiding the object, the stimuli that is in front of them, the situation. And then what is going to happen is that they're going to feel good in the moment, but they're going to reinforce their anxiety because the brain didn't learn that they can overcome the panic attack. And what is going to happen is that they're going to develop beliefs such as, I can stand this, this is too difficult for me, I will never get better, and so on, you see? So that's why one of the things that we use, for example, in exposure therapy, is that we want the client be able to stay with the anxiety that he or she is experimenting. Of course, we help them with some relaxation techniques and some other cognitive techniques that can help them to have control of that experience. But at the same time, we want them to experiment that so they can see that they can overcome that. And once that they overcome that, habituation is going to start activating in them, and they're gonna start decreasing the chances of having the symptoms again when they are in front of the stimuli or the trigger situation that is activating the anxiety. Okay, so now let's go to the symptoms. Palpitations, pounding heart, or accelerated heart rate, sweating, trembling or shaking, sensations of shortness of breath or of smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, unsteady, lightheaded or faint, chills or head sensations, paresthesias, which they are numbness or tingling sensations, like when you are feeling like if you have bugs in your arms or in any of your limbs, actually. Chills or heat sensations, paresthesias, derealization. This is very important. Feelings of unreality. Now, people have lose contact with reality. Panic attack is not a psychotic disorder. So this derealization, it is not that they are living in a delusional thinking or that they are having hallucinations. It is that they are experimenting life in a very peculiar way. The way that they express this is like if I'm in a movie, like if I'm in the theater, something like if this is not real, but I know that it's real. And then despersonalization, being detached from oneself. Again, they are not psychotic. They haven't lost touch with reality. But what they say is like, it's like if I don't have control of myself, it's like if someone else is controlling me. I know it sounds crazy, but that's how I feel it, okay? Fear of losing control or going crazy, and fear of dying. Now, most people with psychotic disorders, they don't think that they are going crazy. So one of the things that I like to say to my patients with panic attack is, you know, I understand it feels very bad, and I understand that you are concerned that you are gonna, excuse me, that you are going crazy. But the reality is that precisely because you are able to realize that, it's very unlikely that you're gonna have a psychotic breakdown, that you are going crazy, okay? So it's important for them to understand that this is anxiety, and that anxiety is a different thing than psychotic breakdown, okay? Now, fear of dying, and now that you have studied these 13 symptoms, you can see why so many people ended up in the emergency room thinking that they have a heart attack, because these symptoms are very, very similar to a heart attack. Now, the difference is that there's nothing wrong with their heart in reality, but they are having this anxiety reaction. And unfortunately, many doctors, when they receive their patients in the ER room, they say something like, you have nothing. And the client is like, what? How do you say that I have nothing? I was dying. And they really feel like dying. It feels bad. If you have ever had one of these, you know what I'm saying. It feels really bad. And they do have something. What they are having is a panic attack. Maybe the cause, the reason is not cardiological problem, but that doesn't mean that it's not real. is so real that you have all these physiological symptoms getting activated, okay? Now, why is that this is getting activated? So there's this great video here. I don't know if YouTube is gonna allow me to play this, but well, I'm gonna try it and see if you can watch it. If YouTube doesn't allow me, then I'm gonna share with you the links in the comments. I will still share the links in the comments because I think that they can be helpful for you, for your clients. I use them as a psychoeducation strategy, okay? So I'm gonna play it and then I'm gonna explain this. Let me go there. Okay, so it's 3 minutes long.
Humans, like all species, have self-protective mechanisms to help us survive. Our fight, flight, or freeze survival response, the FFR for short, is designed to mobilize our brain and body to fight an enemy, run from an avalanche, or freeze to hide from a predator. Our brain sometimes misinterprets safe situations as dangerous and can set off false alarms. When the amygdala, our brain's watchdog, senses and barks danger, our body enters survival mode quicker than our rational mind can react, leaving it trying to figure out why we feel in mortal danger. When the FFF alarm is sounded, we start to breathe more quickly and shallow, causing hyperventilation, and our heart starts beating very fast. These changes can cause strong chest pain, which many people interpret as symptoms of a heart attack, when in fact it's just a result of the FFF activation, which can be relieved through breathing exercises. As a way of getting you ready for action, blood is diverted towards the major muscle groups. Blood flows away from our digestive system, causing the bladder to relax, and we might feel the need to pee. The mouth goes dry, nausea can occur, and we get the butterflies feeling in our stomach. Blood also rushes from extremities, leaving us with cold hands, but often sweaty palms as the action-ready body starts sweating to avoid overheating. Legs and hands can start trembling and feel weak, while tension starts building in big muscles like the thighs, neck, and shoulders. In our head, FFF alarms cause our brain to focus on negative memories, probably so it can scan them to avoid danger and negative outcomes. We get tunnel vision as our pupils dilate to increase our focus and long vision, but as a result, we lose our peripheral vision. FFF activation also reduces our ability to recognize differences in facial expressions. Too much oxygen and too little CO2 can result in dizziness or lightheadedness, which many people interpret as signs that they might faint. But because fainting is caused by a drastic drop in blood pressure, and because the FFF increases both our heart rate and blood pressure, it's nearly impossible to faint when this happens. Over time, depression, anxiety, and high levels of stress all harm the brain's ability to slow or cancel false FFF activations, causing them to happen more often. Knowing the symptoms of false activations makes it easier to recognize and reduce their effects. At Tankyboxing, you can learn both bottom-up and top-down techniques to reduce false FFF activation and bring your body back to balance.
All right, so let me go back to the presentation and I open this. So what happened when people are having anxiety or a panic attack is that they have their fight, flight, or freeze response activated. And this is not necessarily a bad thing. On the contrary, as the video was saying, it's very useful. It has evolutionary purpose. Sorry for that, guys. And that purpose is to keep you safe. So when you are in front of a threat, you need to make a decision. Am I going to fight back? Am I going to fly, run away from here? I'm going to freeze. You know, I live in an area that we have a lot of forest preserves and woods around. And I like to go there to run and to bike and biking and so on. And every day that I go there, I see deers. Sometimes I see coyotes, foxes. And it's very interesting because they have the same response. Actually, all those animals with amygdala, we know that they have this fight, flight, or freeze response, right? So, and when they freeze, it has also an evolutionary purpose because they camouflage. If you don't move, perhaps the other one is not going to see me, and if it doesn't see me, I'm going to be okay. That's what deers like to do. So we as human animals, we also have these three types of response. And as I was saying, it's a good thing that we have it when we are under a real danger, again, such as earthquake, a fire, or if you are in war, or if someone is trying to attack you, because thanks to this response, you're gonna fight back, or you're gonna run away, or you're gonna try to camouflage yourself, right? To hide so the threat doesn't affect you. Now, the problem, and as the video was saying, is that humans, we have two different types of threats. Those which are real threats, such as those as just I mentioned, and threats such as the ones that we say to ourselves. What are they gonna think about me? This is gonna be terrible. I'm gonna feel miserable. No one will like to talk to me. They're gonna think that I'm not capable, or whatever, right? Or for example, the airplane is gonna be used as a weapon, and there's gonna be a terrorist attack, or the engine can stop working and we all are gonna die, or that dog is gonna attack me, and then I'm gonna have a disease and I'm gonna die, and you're like, that little chihuahua, it's like the Taco Bell chihuahua, he's gonna do nothing, come on, you can with the dog, no, it's gonna attack me, right? So they are having internal threats based on their cognitions, based on the things that they are saying to themselves. And the brain doesn't distinguish between real threat or imagined threat. That's why when we are sleeping and we are having a nightmare, we have the symptoms of the panic attack sometimes, right? Some of them at least. And we are in this fight, flight, or freeze response too, even when we are sleeping, because the brain, it doesn't matter for the brain. He's like, you are under threat and I'm going to activate this to try to protect you, okay? And for the clients, it's really important to know that. That's why I use this as a psychoeducation technique with them, because once that they learn that it's normal, that there's nothing wrong with having those symptoms, that activation, that the problem is not that they are having those symptoms, but that the problem is that they are getting activated in situations that are not really matter of life or death, and then they can do something with that. Well, that helps a lot to them, right? They know, oh, okay, I'm not crazy. It's just that I need to configure my system again, right? Something like that. All right, so let's go to talk about specific phobias. Now, the DSM-5, I wrote DMS-5, okay? The DSM-5 is telling us the following, okay? Marked fear or anxiety about a specific object or situation, such as flying, heights, animals, receiving an injection, and seeing blood. Those are the most common, guys, but those are not all. People can have this level of anxiety when they are driving, for example, or when they are, I remember I had a case of a person who, she was phobic to water. Not in the shower, but in any water that resembles the ocean or a lake. So she could not go to a pool. She will never go to a lake. And of course, the ocean was impossible for her, right? So people can get these phobias in many ways, but these ones are the most common: flying, heights, animals, receiving an injection, and seeing blood. In children, the fear of anxiety may be expressed by crying, tantrums, freezing, or clinging. So this is important because sometimes kids cannot express what's going on. Parents can think that it's just misbehaving, and in reality might be a phobia. The phobic object, that's criteria B, the phobic object or situation almost always provokes immediate fear or anxiety. This is important. As soon as the person is in front of that object, the stimuli, situation that they are afraid of it, they're going to experiment some of the symptoms that we saw in the panic attack, or even all of them, okay? So, for example, I remember a client that he used to have elevators phobia. So and it was a very difficult situation for him because he was living in the floor number 7 of a building. So he was going up and down by the stairs all the time. It was exhausting, no kidding about that, right? And as soon as he was in front of the elevator, he was experimenting symptoms of anxiety. Criteria C, the phobic object or situation is actively avoided or endured with intense fear or anxiety. If they can, they're going to avoid it. They don't want to be in front of it. If they cannot, they're going to stay, they're going to endure it, but they're going to be having a very, very bad time. Perhaps now you're going to be saying like, then how is that exposure therapy works? If you are saying that they can be there, endure the phobia, and still having the anxiety, not getting better, why with exposure therapy they get better? Well, there's a couple of things there. The first thing is that what the DSM is telling us is that they endure it with intense fear or anxiety because they don't have option, because they feel forced to do it, because they feel that there's nothing that they can do to avoid that situation. So for example, they have to travel in airplane because his son or daughter is dying in the other side of the world. It's in Europe, right? And they have to go to see the daughter or the son at the hospital. So the dad or the mom says like, I don't have an option. I have to go there and I'm gonna have a very bad time. So they are doing it, but they are not really willing to do it. Exposure therapy works because they have made the decision to engage in the therapeutical process. That's why I personally don't like the floating strategy, because sometimes clients are not completely convinced that they want to do it. And if they are not really convinced that they want to do it, what can happen is that then they can have like a traumatic experience with that instead of a therapeutical experience. So that's the difference. In exposure, it's not a traumatic experience, it's a therapeutical experience, even though it feels very bad. And the reason of why it's a therapeutical experience and not a traumatic experience is because they decide so. They decide to be part of the treatment, okay? And of course, you help them. You help them to decide in that way, and then you help them providing strategies so they can experiment exposure and have a sense of control, okay? That sense of control, I guess that is the crucial, the most important element in exposure therapy. I am in control of the exposure, I can control the situation, and that's why we are telling them what's the level of anxiety that you are having right now? 100, okay, we're gonna stop here. Is that okay for you? Yes, okay, let's go to breathe. Let's go to see what you are saying to yourself. Let's try to calm down. Let me know when you are in 70 or 60 so we can resume our exposure. So they know that it's a controlled environment. The fear or anxiety is out of proportion to the actual danger posed by the specific object or situation and to the social-cultural context. Again, it's a Chihuahua, man. Come on, it's just a Chihuahua. It's gonna do nothing. I want my Taco Bell, right? But they don't see it in that way. That's why it's out of proportion. The fear, anxiety, or avoidance is persistent and typically lasting for 6 months or more. And the fear, anxiety, or avoidance cause clinical significant distress or impairment in social, occupational, or other important areas of functioning, okay? So this is important to have in mind. These fears are affecting their life. This is not like, I'm afraid of sharks. Okay, where do you live? In Chicago. Well, what's the point of doing therapy if you live in Chicago Yeah, so you are not going to have an encounter with sharks. Um, are you a surfer? No. Are you planning to go to the beach? No. So you see, so these are things that really impact the daily life of the person. All right, so these are the types of phobias that we were saying: animals, spiders, insects, dogs; natural environments, such as heights, storms, water, as the client that I was telling you; blood injection injury, needles, invasive medical procedures; and situational, for example, airplanes, elevators, enclosed places; and others, such as situations that may lead to choking or vomiting in children, example, loud sounds or costume character. Someone is calling me, I'm sorry for that. I'm gonna see who's calling. I just hope that it's not an emergency. No, it is not. I'm gonna call later on. All right, so let's talk about the prevalence, all right? So remember, for those of you that are new in this field, prevalence means the number of cases, the possible number of cases that we can see. There's different type of prevalences. There's a 12-month prevalence. That means the chances that a person can develop these disorders in a period of 12 months. There's a lifetime prevalence. So yeah, this is giving us information of how often, recurrent, frequent these type of disorders can be present. And as many as 20% of adults will be diagnosable in their lifetime, okay? So prevalence in lifetime is 20%. Now, in the case of women, they are twice as likely as men to be diagnosed. And this is the case for pretty much all the anxiety disorders. Something that I was explaining to my students the other day is that it's not that the DSM is sexist, guys, okay, or that has a gender bias or something like that, but it is that men and women will react differently to the situations and challenges and adversities that we have to face. Therefore, we see a higher prevalence of the disorders in women when we are talking about anxiety disorders and even mood disorders, okay? But men, we have a higher prevalence when we are talking about disorders that they are related with competitiveness. Sorry for that. For those of you that don't know me, English is my second language, so that's why I have this strong accent. And there are some words that they are still challenging for me. But aggressiveness, competitiveness are the areas that we see a higher prevalence in men. So, for example, disorders such as narcissistic personality disorder, antisocial personality disorder, ADHD, conduct disorder, defiant oppositional disorder. These type of disorders are more likely to happen in men than in women. So it's not that the DSM is sexist, it is that we respond differently to the situations that we are having, okay? All right, so what is the treatment for phobia? Well, there's three types of treatments that they have proved to be effective, that there's evidence base behind them. The first one is exposure therapy. And I will say that's the first way to go to treating phobias. If you are treating someone who has a phobia and doesn't have exposure therapy, you are not going to help that person, okay? That's important to have in mind. This is one of the few disorders that we are very clear. There's like a consensus in research about this exposure therapy, okay? Which it can be in two ways, in vivo, or it can be imagined, okay? Desensitization, for example. And what you do is that you're exposing the person to the objects that they are afraid of. I'm not going to have too much time to explain that here, but the idea is that they have to expose themselves to those situations so the habituation mechanism gets activated and start bringing down the the anxiety that has been activated before. And then the person realizes, oh, I can control this situation. I am in control. This situation is not bigger than me. Now, exposure therapy by itself is a behavioral therapy type, okay? Now, CBT, what do we do in CBT? We do exposure therapy too, but the difference is that we also pay attention to their cognitions. What are they saying to themselves? Is that rational or irrational? Is that based on in an objective judgment, or is that based on your cognitive biases and so on, okay? And we work so they can reframe their way of thinking at the same time that they are exposing to the situation. And it has proved that it's equally effective, okay? But have in mind that CBT is using exposure therapy. That's like the main therapeutical component. And now there's a more contemporary way of treatment that it's virtual reality exposure therapy. As you can see the image, the person has these goggles there, and they are representing the phobic elements or objects that the person is having. And then it's a way of exposure, but it's in virtual reality, right? Now, this goes along, all these three type of therapies, they go along with strategies that can help the client to inhibit the response of anxiety, such as relaxation techniques, or even some of the mindfulness techniques that people are using nowadays. Okay, so all right, so I'm going to skip this. This is about the common errors in our thinking. It's just an explanation of what are these cognitive biases and what are the 12 more common cognitive biases. But what I'm going to do is that I'm going to include the links in the YouTube channel in the comments of the video. So you can go and you can watch them by yourselves. And I will also share other links for more, for some articles that they talk about these cognitive biases, all right? All right, so let's move to social anxiety disorder, also known as a social phobia, but the name in the DSM-5 is social anxiety disorder, okay? And this is what the DSM-5 is telling us. Mark fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. Examples include social interactions, for example, having a conversation, meeting an unfamiliar people, being observed, for example, eating or drinking and performing in front of others, such as giving a speech. In children, the anxiety must occur in peer settings and not just during interactions with adults. The individual, this is criteria B, fears that he or she will act in a way or show anxiety symptoms that will be negatively evaluated. For example, they will be humiliating or embarrassing, will lead to rejection or offend others. Criteria C, the social situation, almost always provoke fear or anxiety. So almost always, okay? It means like it's not from time to time, but it's pretty much a constant experience. In children, the fear or anxiety may be expressed by crying, tantrums, freezing, clanging, shrinking, failing to speak in social situations. Criteria D, the social situation are avoided or endured with intense fear or anxiety. E, the fear or anxiety is out of proportion to the actual threat posed by the social situation and to the social cultural context. And F, the fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more. And again, it's clinically significant in regarding the distress, and it's affecting the social, occupational, or other important areas of functioning of the person. So this is not shyness, guys. This is not embarrassing. This is not nervousness. This is social anxiety, pretty much most part of the time, and it's affecting the life of the person. Now, it can be performance anxiety because they have to give a speech in front of others, or it can be more generalized situations. But the reason of why it's affecting, for example, in the case of performance, Perhaps they are not anxious talking one-on-one, but talking in front of a crowd or many people, right? Well, it can affect for many reasons. On one hand, the person can put their job in a risky position. People with social anxiety, they avoid job opportunities, they avoid dating opportunities, they avoid social gatherings because they are afraid of these situations. So their job, their romantic life, their family life, their friend life, it can be really impacted. So it's not just that they are shy, it's that this is impacting. Now, it is also important to distinguish this from introvert people. People with introversion, which is a personality characteristic, for those of you that wants to know more about this, you can go and read the Big Five test, right? You're gonna, the five characters, the five components of the personality in the Big Five, and one of them is the introvert. Or you can also go and read Carl Gustav Jung. He was the first on talking about introverts, and he actually has also his own test about identifying personality characteristics such as introvert versus extrovert and so on. Anyway, so an introvert person, what is happening is that they enjoy more while being by themselves or just with few people. They perhaps are not comfortable in crowded situations, but it is not because they have anxiety. It's because they prefer a more quiet lifestyle, okay? So generally speaking, an introvert could do well in terms of anxiety when they are in a social situation, but they're gonna choose to avoid those situations as possible because they don't enjoy it. It's different, you see? One thing is not enjoying something, and another thing is suffering because of something, all right? And that's what happened in social anxiety disorder. So the prevalence, 4 to 13% lifetime prevalence. The ratio is 3 to 2 females to males. Onset typically on the teens, which makes a lot of sense because when we start the teenagers, we are much more aware about our social role or place in society. And also we are more aware, according to Jean Piaget, now we have the formal operational skills. We are capable to make, to infer, we are capable to come to conclusions, to use different variables, to have a hypothesis, to have an abstract thinking, and therefore to think about what others are thinking about ourselves, okay? So it becomes a very important element, and actually it also has an evolutionary purpose. Think about the first human communities. If they were not included in the group, they were doomed. That was a condemnation to death because the wilderness was very challenging. Lowest remission of the anxiety disorder. So this is important because therapy can work very well for people with anxiety, with social anxiety disorder. But a certain level of social anxiety is gonna always be present. And I would say in most of us, if not in all of us, right? So for instance, right now I have social anxiety because I know that there's gonna be an audience and that audience is gonna form an opinion about me and so on. But I'm facing that anxiety, I'm doing this, the anxiety is not as bad as not allowing me to do this, right? Now, but people with social anxiety, it is so bad that they will not be doing this. They will be really, really anxious about what others are gonna say, things like that. And not only that, perhaps even if they go to treatment, they will still experiment certain level of social anxiety. So the goal for us, and that's why I'm saying all this, the goal for us is not to have anxiety-free clients. The goal for us is that our clients can be in control of their anxiety instead of the anxiety in control of them. And therefore, that they can be able to have a satisfactory life, even if that means that they still have some level of anxiety. Of course, we're going to try to do the best that we can to help them to decrease that anxiety as much as possible, but also to explain them that to have certain level of anxiety, it is okay. Different expression in different cultures. So this is important, and it's something that I think that it's a good thing in the DSM-5. They are telling us about how disorders are presented in different cultures, right? And this is important because some of the disorders, they really have elements, not only that can be affect the development and the course of the disorder, but also the way that the culture in specific understand those problems. Yeah, but well, just to say, for example, collectivistic societies versus individualistic societies, they express the disorders in different way. Regarding social anxiety, for example, it is different the way that a Japanese is going to express that than an American is going to express that. And it is important to have in mind, for example, Japanese are more reserved, and we need to be sure that they're, how to say this, that maybe the resistance to participate in public gatherings or to perform in front of an audience, it is really because the anxiety or is because of a cultural issue that they have, okay? All right, so what are the treatments? CBT is the one who has proved to be the most effective when treating social anxiety. And it has the following elements, okay? Exposure therapy. Exposure therapy is going to be always important in all the anxiety disorders. Social skills training. Many of the people with social anxiety, they are very good in social relations. It's not that they don't have skills, but what happened is that sometimes they don't know how to use those skills in specific situations. Then you have to help them to learn how to use those skills. And it is true that other clients, they will not have social skills, and improving those social skills is going to be very positive for them because they're going to see, oh, I can be successful when I am in a social situation. And cognitive restructuring, right? Which is pretty much the ultimate goal in all the CBT therapies. All right, so we're going to talk now about agoraphobia. All right, so I'm sorry I had to make a break for a glass of water and to go to the restroom, but we're going to continue with agoraphobia now. I hope that you are enjoying this presentation and that it's helping you to understand better these anxiety disorders and stress-related problems that we are discussing today. All right, so let's go to talk about agoraphobia. The DSM-5 is telling us it's a marked fear or anxiety about 2 or more of the following 5 situations. Number 1, using public transportation, automobiles, buses, trains, ships, planes. Number 2, being in an open space, such as parking lots, marketplaces, bridges. Number 3, being in enclosed places, such as shops, theaters, cinemas. 4, standing in line or being in a crowd. And 5, being outside of the home alone. So that's the criteria A. And remember, guys, you need criteria A for pretty much all the disorders in order of diagnosing, right? So at least about 2 or more, okay, of the following 5 situations. Now, why is that they are having this? So let's continue reading, and then I'm gonna share with you some thoughts. Criteria B, the individual fears or avoids these situations because of thoughts that escape might be difficult or help might not be available in the event of developing a panic-like symptoms or other incapacitating or embarrassing symptoms, such as fear or failing in the elderly or fear of incontinence. So what happened to most of these clients is that they either had a full panic attack in a specific moment of their lives, or they have been dealing with some of the symptoms of a panic attack. And then they start thinking, if this happens in a public place where people are gonna see me, will be really embarrassing and nobody will help me. So little by little, they stop going to these places. In very severe cases, they practically stop their lives and they just live inside of the houses. They find someone to go to do the grocery shops and pay their bills, but their life becomes very isolated, very limited, and very miserable, honestly. The agoraphobic situation almost always provoke fear or anxiety, and are actively avoided, require the presence of a companion, or are endured with intense fear or anxiety. The fear or anxiety is out of proportion to the actual danger posed by the agoraphobic situation and to the social cultural context, and the fear, anxiety, or avoidance is persistent, typically lasting for 6 months or more, and the fear, anxiety, or avoidance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. So as you are seeing, this is just as any other phobia. It's not something that it is not important. It is important because it's affecting the areas, all the areas of their lives, or most of them. Now, the difference with the other phobias is that if you are afraid of dogs, if your phobia is to dogs, well, you can go to work, you can go to a mall, you can do many things because you know that dogs will not be out in the sense of, how should I say this? You know that many of those places are going to be restricted for dogs, right? Or if you have a phobia to airplanes, well, you can still go into work and having a social life as long as you are not in an airplane, right? But in the agoraphobia, the fear, it's not the parking lot. The fear is not the train. The fear is not the marketplace. The fear is that people are going to see that you have anxiety and that you will not be able to escape, or that it's going to be very embarrassing. And that in that situation, perhaps nobody's going to help you. So it has to be with the place, with the situation, but it is not just the place or the situation. Perhaps they could be there if there's nobody, if it's completely empty. But the fear is that if they are there and there's people there and they have symptoms, people are going to realize and they will not be able to escape. So it's very challenging because you cannot get rid of people. It's just like in social anxiety. It's very challenging because you can just not get rid of people, right? Okay, so what are the treatments for panic disorder and agoraphobia? Now, this is important. I was saying agoraphobia, now you're gonna be like, oh, why is that you are talking about panic disorder and agoraphobia? Well, because agoraphobia usually goes along with a panic disorder, which means that you are having panic attacks with a certain frequency, okay? So that's why I'm including this here. A panic attack is not a disorder per se, but a panic disorder, it is a disorder when you are having panic attacks, and it can be along with agoraphobia too. So structured exposure therapy, or CBT, should include education about the nature and physiology of panic attacks. So psychoeducation, I would say psychoeducation is in all type of, in all the disorders. We need to help them to understand their disorder better. Breathing training designed to control hyperventilation, cognitive restructuring therapy, interoceptive exposure to reduce fear of harmless body sensations, prevention of safety behaviors that may maintain attacks and avoid disconfirmation of maladaptive threat beliefs. So this last one is very important, okay? So those safety behaviors are an avoidance strategy. So I will go only if my sister goes with me, and if it's after 8 p.m., and if there's nobody there, and you see? So these are the safety behaviors. And we want them to see that those safety behaviors in reality are not helping them. In reality are reinforcing their disorder. And the more that they do it, the more difficult it's going to be to get rid of the disorder, okay? Or, yeah, alleviate their symptoms. That's a better way to say it. Okay, generalized anxiety disorder. This is a very challenging disorder too, because the person is worried, concerned pretty much all the time. I remember a client that I had, it was even difficult to see him because just seeing his body expression, the way that he was moving, you can notice that he was having a very difficult time. So yeah, let's go to talk about the symptoms. So criteria A, excessive anxiety and worry, apprehensive expectations occurring more days than not for at least 6 months about a number of events or activities such as work or school performance, or all of them. The individual finds it difficult to control the worry. The anxiety and the worry are associated with 3 or more of the following 6 symptoms, with at least some symptoms having been present for more days than not for the past 6 months. In the case of children, it's only 1 symptom that is required, okay? Restlessness or feeling caught up or on edge, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, and sleep disturbance. So what's the prevalence? The ratio is 2 to 1, women to men. 5% of the population will be diagnosed in a lifetime prevalence. Comorbidity from 45 to 90%, which is really interesting. Comorbidity, for those of you that are not familiarized with the word, is it's a concept that allows us to see if it's common or not, if it's frequent or not, that the disorder it's present along with others disorders with more than 1 disorder, right? And that's very common in mental health. That's why there's this tendency now to talk about spectrums disorders, such as autistic spectrum disorder. Instead of having Asperger and autism as separate, they're talking about spectrums because they share many of the symptoms. That's also why there are authors talking now about these transdiagnostic treatments, because it's not really clear, 100% clear, that we are talking about specific identities in these disorders, or if they might be part of something more common in the form of a spectrum, right? Many clients with general anxiety disorder, they experiment depression, they experiment other types of anxieties, such as social anxiety or bipolar disorders. So the comorbidity is really high, 45 to 90%. Depression and eating disorders are common. Yeah, so what are the treatments? Okay, so some medicines, pharmacological treatments have proved to be effective. such as the SRIs, selective serotonin reuptake inhibitors, also the SNRI, and for severe cases or those that don't respond to CBT, we should be using these medicines, okay? Now, stimulus control treatment, reducing the time and context in which worrying occurs. I will say this is more a technique than a treatment per se that needs to be used with the clients, regardless if it's treated by CBT alone or CBT plus medicines. Well, self-monitoring, relaxation training, cognitive restructuring, and behavioral rehearsal in CBT. This behavioral rehearsal, they are ensayos, right? They are like practicing, helping the client to putting the client in situations where they will experiment the anxiety and then helping them to see what are the options to handle both the situation and the anxiety that they are experimenting. All right, so let's move now to obsessive compulsive disorder. And I have this recommendation for you guys. I know it's an oldie, but not all these are bad, guys. I say that especially to my students in the bachelor program, that they are generally speaking young people. Actually, in my class of lifespan development, one of the assignments is that they have to watch Gattaca. I don't know if you have watched that movie. It's a dystopian movie about genetics and society. It's an awesome movie. And they all are like, wait, what? I was not even born and you are letting us to watch this movie? But every time that I read their assignments, they are like, oh, this was mind-blowing. It was an awesome movie. Anyway, this is a good movie too. I'm not a super fan of Nicolas Cage, but I think he did a very good job in this movie. Yeah, Matchstick Man, it's the name of the movie, and he has obsessive compulsive disorder. I'm not gonna spoil the movie, go and watch it. The reason of why I'm sharing this for you is so you can have a clear picture on how an obsessive compulsive patient looks like, and he did a good job with that. There's other movies like that of Leonardo DiCaprio, and about a airplane pilot. I don't know the name in English. And Jack Nicholson also has another one, but I think this one is more accurate, at least based on my experience with my obsessive compulsive patients. It seems so. All right, criteria A, presence of obsessions, compulsions, or both. So you cannot have a diagnosis if at least they don't have obsessions or compulsions or both of them, okay? Now, what are obsessions and what are compulsions? So obsessions are cognitions that are bothering and activating the anxiety of our client. And compulsions are behaviors, sometimes also cognitions, to try to decrease the level of anxiety that the obsessions have caused in the patient. So let's see what the DSM is telling us. Number one, obsessions are defined, number one, as recurrent and persistent thoughts, urges, or images that are experienced at some time during the disturbance as intrusive and unwanted, and that in most individuals cause marked anxiety or distress. Number two, the individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action. Okay, so we all have intrusive thoughts. And that's especially true when we are under stress and anxiety, and sometimes can be even disturbing, right? But most of us will be like, why am I thinking this? I need to stop thinking this, I'm gonna do something else. And then the thought goes away. Or we have an inner dialogue and we say like, no, this is not the way that I think, this is not rational, so I'm gonna change this way of thinking, and it goes away. The problem with people with OCD is that their obsessions, they don't go away that easily. And not only that, they see those obsessions, those thoughts, those images as a real thing. And because of that, they get very activated. What type of thoughts they have? Well, thoughts of harm. For example, I kill someone. While driving, I kill someone. Thoughts of being contaminated, just like what is going on right now with COVID, right? I think that we all are having an experience of how OCD feels like. Do I have the virus? Did I touch someone? What if I get the virus? Did I touch my face after saying hi to that person? Am I having symptoms of it, right? Those are more contamination type. Then there's the order type. People who have thoughts about counting numbers, counting lines in the street, counting blocks in a building. Then there's about being dirty, not necessarily contaminated, but being dirty. My body is dirty. Safetyness. Did I close the door? Did I close the garage? But this, you need to have in mind, we all have these thoughts. But as I was saying, most of us are able to say like, yeah, yes, I did close the door. Or just going once and just double check and that's it. But in the case of them, it doesn't work like that. And actually, every time that they do something with their thoughts, that they are using behaviors to reduce the amount of anxiety that the thoughts are activating, they are reinforcing the disorder. That's compulsions. That's the definition of compulsions. Let's go to read it. Repetitive behaviors such as hand washing, ordering, checking, or mental acts such as praying, counting, repeating words silently, that the individual feels driven to perform in response to an obsession or according to rules that must be applied rigidly. The behaviors or mental acts are aimed at preventing or reducing anxiety or distress, or preventing some dreaded event or situation. However, these behaviors or mental acts are not connected in a realistic way with what they are designed to neutralize or prevent, or are clearly excessive. In young children may not be able to articulate the aims of these behaviors or mental acts. These obsessions or compulsions are time-consuming, take more than an hour per day, or cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And these obsessive compulsive symptoms are not attributed to the physiological effect of a substance or another medical condition. So, literally, people stop having a life because they are engaged in the cycle of obsession and compulsion. People can spend hours and hours and hours in the shower because they think that they are dirty. And once that they finish, they start drying, and then they are like, what if the towel was not completely clear? So now I need to clean it. So now I need to go to the shower again. And they go to the shower and they start everything again. Or people can stop working, having a social life, because they are so concerned of getting a bacteria or virus or a disease out there, such as what we are doing right now with the lockdown. We are in an obsessive compulsive time of history, I will say, all right? Now, the difference is that we do have a real threat. We have a pandemic. This pandemic, we know the virus spreads very easily. Therefore, what we are doing is not irrational, at least not 100% irrational. Some of it is. But in the case of them, the threat doesn't exist, or not in the way that they are seen. Of course, there's virus. Of course, there's bacteria everywhere. We have more bacteria than human cells in our body. And we have learned to live with them. So the way that they are feeling this is not accurate with reality. Same thing when it's about safetyness or when it's about order or things like that, okay? So I suggest you to buy this book. The Man Who Couldn't Stop by David Adam. It's a biography of a guy with OCD and how he faced his OCD and how CBT helps him to his OCD and so on. There's an onset in early adolescence or early adulthood. The lifetime prevalence is 2.5, so it's not as prevalent as the others, and more women than men. These are some OCD-related disorders, and I'm sharing a TV show that it's in A&E. Okay, Hoarders is the name of the TV show. Body dysmorphic disorder. So the person thinks that something is wrong with her or his body, and that therefore they need to change their body. They need to amputate a hand. They need to have a surgery to change the way their body looks like. And they can. I remember a lady telling me, my right breast is way bigger than the left one, and I measure them every day, and I go with the doctors, but they don't want to have a surgery with me, and so on, right? One arm is longer than the other. And yes, we all have some differences. We're not perfect, but they really think they are really different, and therefore they want to have surgery, medical treatments. Hoarding disorders, such as the picture, these are really, really devastating disorders because people stop having a life, accumulating things, and they are very dangerous. That's why you see the firefighter there. Imagine a spark in that room. It will be crazy. Trichotillomania, and there's another one that is called trichotillophagia. And trichotillomania is people that they pull their hair out. It could be the hair from their head, from the armpits, from any part of the body. I'm not going to say more because of, yeah, otherwise they're going to rate this video as a PG-13. Okay, and trichotillophagia is when they eat that hair, okay? And skin picking disorder, they are constantly picking their skin, okay? So these are OCD-related disorders. These are in reality OCD disorders, but they have this way of manifestation. And I will also include anorexia nervosa here. People with anorexia, they behave very much as OCD people. Now, you might be wondering what's the difference between OCD and OCDP, obsessive compulsive disorder or personality obsessive compulsive disorder. Well, this one is anxiety and the other one is a personality disorder. In the other one, they do not have obsessions and compulsions. They do have a rigid pattern of life. Their personality is rigid. They can have obsessive patterns of thinking, but not obsessions. That means that they can be very extremely structured, extremely, as we generally say to someone, that's obsessive, man. Stop saying that or stop thinking in that. But it's different. That's a personality disorder. This is an anxiety disorder. They are having symptoms of the panic attack that we saw at the beginning of this explanation. So what are the treatments? Exposure and prevention treatment, also known as exposure and ritual prevention. And it has two components, okay? And this is the most effective. You need to work with this with them. One, graded exposure to the situation and thoughts that trigger distress. And two, ritual or response prevention, such as practicing competing behavior, habit reversal, or modification of compulsive rituals. So the thing is that every time that you have an obsession, and then you have a compulsion because the obsession is causing so much anxiety, and then you have the compulsion to try to reduce that level of anxiety, you're going to feel good, right? If I think, oh, I shake hands with someone, I'm going to wash my hands because of the coronavirus. You wash your hands and you're like, I feel good. I'm not going to have the coronavirus. Anxiety, go away. Now, that works good for people who doesn't have OCD, but if you have OCD, you wash your hands and you are like, okay, now I'm safe. But wait, what if I didn't wash appropriately? Let me go and spend 10 more minutes washing the head. Then they finish and then they are like, oh, I think that I didn't wash under my nails. I should go back and wash again and again and again and again. So what is happening is that the compulsion is reinforcing the obsession, even though it's helping at the moment. Not only that, the compulsion ended up working as an avoidance strategy for them. So we need to help them to stop the compulsion. People spend too much time working with the obsessions, which is not a bad thing to work with the obsessions, but they don't spend as much time working with the compulsions. And if you don't work with the compulsions, you are not going to help them. So yeah, CBT, along with the exposure and relapse prevention, you use psychoeducation of intrusive thoughts, challenging beliefs like responsibility appraisal, overimportance of thoughts, exaggerated perception of threat, and behavioral exercise, and pharmacological and neurosurgical treatments. So the SSRIs have proved that they can work with these clients, and in cases that are really, 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 really severe and that CBT is not working, the SSRIs are not working, and so the cingulotomy, it's a type of surgery where they destroy cells in the cingulum, and for some reason it works, it helps these clients. Okay, but I'm always like, that's the last option because it's not reversible, right? All right, and this is the last disorder that we're gonna see. We made it, okay, well, almost. So post-traumatic stress disorder, which is one of my favorites. I have done research on PTSD. I also did my PhD on it. I have some papers published on PTSD. I'm gonna share that with you in case that you want to read it. Some in English, some in Spanish. Okay, so let's go and talk about it. The DSM is telling us that criteria A is exposure to actual or threatened death, serious injury, or sexual violence. Okay, so you have been exposed to something that was a real threat or that it was a real injury or sexual violence. Criteria B, intrusion symptoms associated with a traumatic event, such as thoughts, images, dreams, flashbacks. Okay, so the person might be, for example, watching the TV, and suddenly while watching the TV, something comes out of in the movie and activates an image of the traumatic event. And that can activate the symptoms again, right? The person is having dreams, flashbacks, images, thoughts coming into their mind. Those are the intrusive symptoms. Persistence, avoidance of stimuli associated with the event. I don't want to talk about that. I don't want to see anything about that. I am not going there, right? They are avoiding the situation. There's a negative alteration in cognition and mood associated with the event. So depression is very common on these clients. Of course, anxiety is very, very common. That's why the DSM-4 used to be part of the anxiety disorders. And there's alterations in arousal and reactivity associated with the event. So every time that they remember or they are exposed to something that it's similar to the event, they're gonna have an arousal reaction, right? Either with symptoms such as the panic attack, or also with hypervigilance, trying to see that they are okay and so on. Now, one of the things that we want to have in mind is that PTSD can also be developed by knowing about the traumatic event. So that's the vicarious PTSD. And it's common in therapists, counselors, psychiatrists, psychologists who work with PTSD. You need to be aware of that. You can develop PTSD because you are working with the PTSD of your clients. Or some people can develop because they have, they learn that a loved one experienced the traumatic events. So for example, I work in my research, I work a lot with people who they were kidnapped in my home country, which is Mexico. And they were kidnapped by the drug lords there. And after several weeks of being kidnapped, they are released, right? And they have all the symptomatology after a while of the PTSD, but not only them, also their wives or their husbands or their children, because they are also victim of a traumatic event such as that, okay? All right, so what's the prevalence? 50% of population will experiment at least one potential PTSD event. What does this mean? It means that traumatic events are part of our daily life, okay? They are part of our daily life. But it is important to have in mind that not all people are gonna develop PTSD. Most people are gonna overcome these potentially traumatic events in their lives, okay? So yeah, you can have a very bad car accident, you can be in war, and not because of that you're gonna develop PTSD. That's why there's a debate between what is trauma? Trauma is an event or trauma is a response to the event? And I am more in the side of saying trauma is a response to the event, because many people will suffer very traumatic experiences or possible traumatic experiences and not developing traumatic reactions, okay? 70 to 90% of rape are victims, 50% of prisoners of war are gonna develop PTSD, 20 to 25% of earthquake and flood survivors, 50% of motor vehicle accidents. And something that we need to have in mind is that there's another disorder that is called acute stress disorder. It's pretty much the same disorder. The difference is that it's less than 1 month. And this says something about the way that we react to these events. We need a time to process the experience, and it is okay to feel bad. But if after a month you continue with the symptoms, then the diagnosis moves from acute stress disorder to post-traumatic stress disorder, okay? And these are the type of treatments. So I just want to share a couple of names here. I don't have it in the PPT. Yeah. Prolonged exposure therapy by Edna Foa. It's a very, very good therapy, evidence-based therapy. It has the components that you can see in this box. It will help to extinguish association between trauma cues and fear responses. It will help individuals to disconfirm any symptoms maintaining dysfunctional beliefs that have developed as a result of the trauma. Probably it's the pioneer on treating PTSD, Edna Foa. Prolonged exposure therapy, it's known the therapy, okay? Beautiful therapy. Now there's other type of therapy that I really like. I have done research on it, very effective as well. And it's more in the side of the cognitive restructuring therapies. And it's called, sorry guys, cognitive processing therapy by Patricia Resig from the VA Institute, okay? Cognitive processing therapy by Patricia Resig. And there's something very nice for you to know. They are offering free training and certification on cognitive processing therapy in the VA Institute. How do they work? Challenging of dysfunctional beliefs, such as the world is a dangerous place, I'm totally incompetent, was my fault, just work belief. But they also use a different type of exposure therapy, which is writing accounts of the event, okay? These therapies, they are protocolized. There's a protocol that you go step by step. The cognitive processing therapy is a 12 meetings treatment, 50 minutes each session, very effective. In 12 meetings, patients can be out of their PTSD. And exposure therapy, if I remember well, is very similar. Yeah, between 12 and 16, if I remember well. Now, there's another one that is the eye movement desensitization and reprocessing. the famous EMDR. What they do is that they activate the traumatic memory, and then the therapist is moving the finger, or sometimes are sounds, noise going from one direction to other, and so on. And then they help the client to try to process the traumatic memory. Now, I'm not so sure about eye movement desensitization and reprocessing. There's research about it, but it's also under copyright, and some authors have not been authorized to do research about it. And it's not really clear what's going on, what's the therapeutical process going on to help these clients. Is the finger of the therapist? Is the sound that they are listening? Is the re-experimentation of the memory? What is it? It's not really clear, the process. Now, in exposure therapies and cognitive restructuring, it is very clear because it is exposure along with the restructuring process of the beliefs and cognitions associated to the traumatic event. Anyway, so that was the last one. So I'm gonna stop sharing this. I hope you guys enjoy it, that you like this video, this class about anxiety and stress-related problems. Of course, this is an introduction. Again, if you're a counselor, psychologist, psychiatrist, or you're a student, you need to buy your DSM-5. You need it. Even if you don't like it, you need it. You need to get familiarized with it. You need to understand the disorders here, how the DSM works, right? And as I say at the beginning, this is a good book that you can buy as well, that it will provide a context to understand each of these disorders, the etiology of the disorders, what are the epigenetic elements of the disorder, what are the environmental elements of the disorder, and also the treatments. I did a summary of those treatments here, but you're gonna see here the evidence behind the treatments and so on. All right, so I hope you like it. Don't forget to subscribe to the channel, to like the video, and you can leave your comments as well. I'm gonna be happy to answer those. And if you have any question, if you're working with anxiety clients, if you're working with a specific type of treatment and you want to share that with us, I will be happy to read that too. All right, so have a good one, guys.